I come to this because I recently was ill myself and had to navigate the patient portal, which I found I had to demystify on a daily basis because the patient portals are not so user-friendly always. So I'm going to start with a sort of a consultation that I had as an example. A 68-year-old female who is pretty healthy, only a past medical history of hypertension, but she had fatigue and some fullness and had noticed something underneath her left costal margin and had mild anemia. She had a CBC done before she saw me with a white count of 21, a hemoglobin of 10.8, and platelets of 126. And on her physical exam, her spleen was 5 centimeters below the costal margin. So at this consultation, we decided to do a bone marrow biopsy, which was done and showed that it was hypercellular for her age with abnormal clustered megakaryocytes and some fibrosis. She had a karyotype done with her cytogenetics, and her cytogenetics were abnormal, showing a deletion of 20q, which is something that can be seen in patients with MPNs. And she had an NGS panel sent that was positive for mutations in CALR, TET2, and ASXL1. 1 week after the consultation, the results from the bone marrow were reported in the patient portal. And she called, and we went through an extensive discussion of the bone marrow results. And she was reassured. But then 3 weeks later, after the consultation, the results from the NGS panel were reported in the patient panel. She immediately went to do a Google search. She was alarmed by seeing the ASXL1. And the first thing she saw was this annotation: ASXL1 mutation confers poor prognosis in primary. She didn't have to read further, but she understood that ASXL1 would be a poor prognosis finding. But then she also saw this in her Google search, not far below it. She's looking at a large analysis done by Paz et al., where it looked like ASXL1 mutations without TP53 or high-risk mutations have no prognostic impact in myelofibrosis. And she was confused. She wanted to know, what does this mean for me? Why do I need to worry? Do I need to worry? I like the paper where ASXL1 confers good prognosis. What do you think? So we started a conversation about scoring systems and myelofibrosis and how we make a decision as to how we're going to think about treating a patient. And there are many, many scoring systems out there, the most traditional being the IPSS or the DIPSS or the DIPSS plus, or the MIPSS-70 or the MIPSS-72+2 or the GIPSS. And as I told her, when we don't really know what to do with patients, we have an abundance of scoring systems, and then we have to figure out what it is we're going to do. So as we were talking, she said, all of those scoring systems give me headache and anxiety. And she wanted a prescription for diazepam, and I suggested that she take an Advil instead. So the most widely used scoring systems are the IPSS, the DIPSS, and the DIPSS+. And these are 3 scoring systems that are sort of used interchangeably, and it's rather confusing when patients are enrolling on clinical trials, because any of these scoring systems can be used as a scoring system that confers your eligibility, for example, to clinical trial. The IPSS is unique in the fact that we apply it at diagnosis. And factors which are important are age, the hemoglobin level, leukocyte count, your blast count, and any constitutional symptoms that you may have. And you're organized into low risk versus high risk categories. DIPSS is an improvement in the sense that it can be used anytime during your treatment. It's the same categorization as IPSS, and again, low risk to high risk categories. The DIPSS plus is meant to be an improvement. It's the same as the DIPSS, although the platelet count becomes relevant and what the transfusion needs of the patient might be. And karyotype becomes a factor in this scoring system. But as I said, these are usually the most common scoring systems, and any one of them can be used in a clinical trial eligibility, for example. But now that we have molecular data and our patient knew her molecular data, were there scoring systems using molecular data? And there are. There's the MIPSS-ET, which incorporates, just to make it ultra confusing, the same criteria as the GIPSS, but the age categorization as to where there's risks a little bit different. There's a higher blast count used, and whether or not there's bone marrow fibrosis. But also looking at mutations, the absence of CALR or the presence of high-risk mutations like ASXL1, SRSF2, EZH2, or IDH1 or 2. The MIPSS-ET version 2 is the same criteria as the MIPSS-ET, but sex and severity of adverse hemoglobin levels are acknowledged in this scoring system, as well as karyotype, an unfavorable karyotype, or a very high-risk karyotype, and the same mutations as the MIPSS-ET, but if there's greater than 2 mutations, that can be important in determining your risk. And this categorization is a little more sensitive, going from very low risk to low risk, up to high risk to very high risk. There's also the GIPSS, which is a genetically inspired prognostic scoring system, where your age, your sex, your hemoglobin levels, your platelet levels, none of those are important in this scoring system. Just whether you have a favorable or unfavorable karyotype, the presence of AXL1 mutations, if there's an SSS2 mutation, which is considered high risk, or an A2AF1Q157 mutation, which is also high risk. And again, this scoring system looks going from a low risk with an overall survival of almost 27 years to high risk with an overall survival of about 2 years. Now, this discussion of the different scoring systems and how we could look at her disease also inspired another request for a prescription for diazepam. I talked again about other classifications in myeloproliferative neoplasms. She said, is there calculators or something that I could look at online to determine my risk? And I pointed her to the Grinfeld study, where there is, in fact, a calculator, where there are a number of patients who are on this study. And if you can find a patient that matches you, you can use the calculator and try and figure out your overall survival. So she went online, looked at the calculator, found a patient that might be a little bit like her, and using the calculator, the median overall survival was calculated at 3 years, and she panicked. So now that we have all of these scoring systems, what's the best way to use them? And how good are physicians actually at assigning risk to MF patients themselves? And how available are scoring systems to patients? For example, here, there's the online MIPSS-ET score system, which can be accessed just by going to Google. Interestingly, in a study of real-world assessment and treatment initiation and community practices in the United States using the IPSS, DIPSS, and DIPSS2, they looked at the accuracy of risk stratification by physicians in the community practices in the Cardinal Health Oncology Provider Extended Network. 491 patients were enrolled or looked at in this trial between 2012 and 2016. And the risk categorization only occurred in 30% of patients, with scoring systems that were actually real scoring systems used in only 50% of those. And compared with data-derived risk categorization, 42.9% of physician-assigned risk categorization was inaccurate. And 89% of incorrect physician-assigned risk categories were underestimations. And 38.5% of patients with data derived as intermediate or high-risk disease were underestimated by the physician assessment, and they did not have treatment or transplant evaluation initiated within 120 days after that score was assigned to them. So the fact is really quite true that physicians may not be very good at using these scoring systems and giving the right risk assessment to a patient. There are also scoring systems for ET and PV that incorporate molecular data. The traditional scoring systems for ET might be something like the MIPSS-ET score, where age is important, history of thrombosis, or the presence of a JAK2 mutation. There's a traditional scoring system for PV, is really the International Working Group Prognostic score. Age is also important, what the white count might happen to be, whether it's high or normal, and whether there's a history of thrombosis. But the MIPSS-ET incorporates molecular data. The scoring systems confirm the independent survival effect of adverse mutations, such as those listed there, age greater than 60 years being a risk factor, and male sex. The MIPSS-PV is a scoring system based on 4 risk factors: the presence of an adverse mutation, whether or not there's an abnormal karyotype or the chromosomes, there's an abnormality. The age is a little bit different. In this, it's age greater than 67, and a high leukocyte count greater than 15. So using the mutation-enhanced international prognostic systems for ET and for PV do show a better stratification of risk, where you can see patients who have low-risk disease have really a pretty good overall survival over time compared to those with high-risk disease. Are these scoring systems helpful? And why are they helpful? And should everyone who presents with MPN have molecular testing? Should everyone have a bone marrow biopsy to determine what their karyotype might be by cytogenetics? And how can these scoring systems best be used? So the first question, who should have molecular testing? One of the strongest risk factors for prognosis is really age, and older age in particular. So those patients older than 60 may really benefit from molecular testing because you can identify in a relatively healthy 60-some-year-old who might have poor molecular risk, whether or not they're a transplant candidate, and to advance on that idea quickly. Younger patients, though, without any other adverse risk factors, such as a high white count or a thrombosis history, may not need molecular evaluation, although it may be helpful to set a baseline to follow throughout their treatment trajectory, particularly as we have more and more agents that are targeted to specific molecular abnormalities. Is there a role for bone marrow biopsy at the initiation of seeing a patient with a myeloproliferative disease? And what's the role of cytogenetics or a karyotype? How important is this? The studies of molecular prognosis in ET and PV and the search for risk factors implicated in overall survival were really hampered by the risk of karyotype information. That when they went back and looked at all of these patients, so few of them actually had karyotypes at baseline that it was really hard to know how important it was really in the prognosis of their overall disease. So we don't really know the answer by looking at studies. Too few patients had a bone marrow biopsy at diagnosis, and I think that's true in the community. And certainly in patients that I see, patients are diagnosed with ET or with myelofibrosis, but they haven't had a bone marrow biopsy, and there's no karyotype, and there's no morphologic evidence as to what their disease might actually be. And whenever karyotype information is available, it does need to be factored into the risk assessment of patients. Sometimes patients have very adverse karyotypes, which may not have very severe-looking molecular abnormalities, but those patients might need to be considered as more high risk. And one of the most important things I think about a bone marrow biopsy, it allows you to determine the difference, for example, between whether a patient has essential thrombocythemia or early pre-fibrotic myelofibrosis. And that might be very, very important, especially in evaluating things like spliceosome mutations. When you look at the studies that were done, looking mainly at patients in Europe and patients at the Mayo Clinic, it looks like that spliceosome mutations may have just been present in patients who had early myelofibrosis, but they didn't have bone marrow biopsies actually to show what their disease was at baseline. So there are a lot of complexities to looking at these studies, and many of them could be helped if there were bone marrow biopsy information available to look at. Back to our patient with MF with CALR, TET2, and ASXL1 mutations. If I used all the scoring systems, what were the results? So in 4 of the scoring systems, she had high-risk disease. On 2 of the scoring systems, she had intermediate 2 disease. Regardless, she had pretty advanced disease, even though she felt relatively healthy, except for fatigue and splenomegaly. And when we began to talk about treatment recommendations using risk-adapted type analysis, we have to discuss that the only curative therapy is allogeneic stem cell transplant. And this is a very difficult discussion with someone who seems very healthy, really, other than the fact that they have early myelofibrosis. And they may actually balk at the idea that they undergo a procedure with roughly a 50% mortality rate at 2 years. All other available treatments are palliative. And when there's so few effective treatments, I always underline the fact that there's an abundance of scoring systems to assign prognosis, making it more difficult. The scoring systems do, however, help guide when to send patients or when to discuss with patients a stem cell transplant evaluation. And using, for example, the MIPSS-plus, looking at a treatment algorithm, you look at the very, very low risk, which Dr. Mesa referred to as those very few patients that we can follow really with observation for a period of time. And low risk and low intermediate risk, who are treatment requiring, we can either decide to put them on a clinical trial, such as the combination therapies that were introduced by Dr. Mesa earlier, or to treat them with conventional treatment like ruxolitinib. But when you get to higher risk or very high risk disease, those are patients with whom you have to have a very important discussion about stem cell transplant and about that sweet spot where they're good enough to be transplanted before they get too sick to be able to be transplanted. And that's a very sweet spot for which there's a lot of ongoing discussion. If they happen to be transplant ineligible, for example, their EF is low, they don't have a good ejection fraction, or they have so many comorbid illnesses that they're not good transplant candidates, really the best therapy to choose is really one on clinical trial, if you can find one that fits the patient. There are conventional therapies that are based really on the indications or symptoms that a patient may be experiencing. If they have anemia, we have lots of medicines to try and improve that. Splenomegaly, we have the JAK inhibitors now, Rux, fedratinib, and pacritinib. We have for constitutional symptoms, the JAK inhibitors, and interferon potentially. And for bone pain, ruxolitinib and interferon, and potentially even some of the other JAK2 inhibitors. For bone pain, also radiation therapy can be used if the patient is not transplant eligible. Dr. Mesa went through, there are lots of opportunities to put patients on clinical trials, and there are lots of clinical trials available. And if you have advanced myelofibrosis and are hesitant about embarking on a transplant, or you're transplant ineligible, it's really important, I think, to consider these options. And our patient, based on the scoring that we discussed closely together, we decided to refer her for a bone marrow transplant evaluation just to see what kind of match she happened to have. Her best donor was a haplomatch. She had an estranged sister who was not tested, and she would not put forward for testing. And she chose to be enrolled on a clinical trial with the BET inhibitor plus ruxolitinib. But these discussions are difficult. We're just getting to really understand the importance of molecular data and assigning prognosis to our patients with myelofibrosis, polycythemia vera, and ET. And we're still learning, really, at which patients may be at higher risk of of progression needing a transplant earlier.